Hi, good morning, and welcome on this bright, clear, brisk day to the first lecture of the spring semester for the Department of Medicine Grand Rounds. I was going through our schedule for the semester with Avinash earlier this week, and Avinash has done a great job. We're really excited about the lectures we have coming up in the next few months, and excited to be sharing a lot of great wisdom with all of us and inviting folks from within the department and without to join us in this important forum. Today, we're really thrilled to have Elizabeth Singer with us, who is the director of Mount Sinai's Human Rights Program, also director of research for the Division of Global Health and Emergency Medicine, and she's an associate professor in the departments of medical education, as well as the Department of Emergency Medicine, and does a lot of her work, as I think many know, here at Mount Sinai St. Luke's. She received her MD from SUNY Downstate and then completed a residency in internal medicine at Bellevue Hospital Center, and then her emergency medicine residency at Mount Sinai, also completing a Master's of Public Health in forced migration and humanitarian assistance at the Mailman School of Public Health at Columbia University. And in the ensuing 20 plus years has really had a remarkable career working with organizations such as Health Rights International, Libertas Center for Human Rights, and the Clinton Health Initiative across the globe in countries in Africa, East Asia, South America, working perhaps first and foremost with individuals and families, supporting them through their experiences in forced migration, but also importantly, and as we'll learn today, helping us to much better understand the impact on the personal level, as well as at the population level of forced migration and other rights abuses that occur for many, many, many people across the globe. Most recently, she's been doing some work on our very own border to the south. And Elizabeth, we're really just delighted to have you with us today, and welcome.
So thank you so much. Thank you for that lovely introduction. And thank you, Avinash, and to all the chiefs for inviting me here today. I know we are sharing with our friends at West and other places, so hello. Okay, so I just want to start out by saying I do not have any conflicts to disclose. So today I thought we're going to speak about the current trends in forced migration and review a little bit about the impact of mental health and physical health that immigration and forced migration has on patients, and then also talk a little bit about the screening methods that you all can use and we can use in a primary care and internal medicine setting to potentially find asylum seekers in our midst, and then also talk a little bit about the educational benefits of working with asylum seekers for residents and students. So just to get like a quick show of hands, how many of you are seeing patients in your practice that are refugees or asylum seekers who have histories of persecution? 1, 2. I know that Dr. Shapiro is definitely one of our evaluators, so yes. But I would go out on a limb and say that actually all of you, most of you, if not all of you, are seeing these patients in your practice. You may not know that they are your patients because oftentimes asylum seekers are what we call a hidden population. They don't always come out and tell you that they are who they are. Oftentimes people don't want to talk about their migration, their immigration status if they're undocumented. So I think these are patients that we are definitely seeing in our midst. If we're practicing in New York City, we have a very large refugee and asylum population. So they are here, they are with us, and it's a matter of sometimes really asking some questions, which we'll talk about a little bit later, to identify them and maybe help them in ways that we might not be able to if we don't identify them. So I'm going to talk a little bit about the trends in forced migration, the recent trends that have been going on worldwide and in our country, and then we'll talk about a case and go from there. So just to start off, this is a case that we saw in our program. Name has been changed and a little bit of the facts have been changed, but his name is Isaac. And he was born in Lagos, Nigeria, which is in Western Africa. Lagos is the largest, one of the largest city actually in Nigeria. And he identifies as a bisexual man. He fled Nigeria in 2016 after he was kidnapped and tortured by an anti-gay vigilante group. And that's a very common thing in Nigeria. Nigeria, as well as many, many African countries, banned same-sex marriage. In 2013 in Nigeria, there was an act that basically made same-sex marriage and same-sex activity illegal and punishable with up to 14 years in prison. And it's very common in Nigeria and other countries in Africa for vigilante groups to take matters into their own hands and to kill or severely injure people that are suspected to be LGBTQ. So the map really shows, it's hard to see different colors on this here than on my screen, but the areas in green are places where you can be in prison for anywhere from a year to like 10 months for if you are found to be LGBTQ. Nigeria has a punishment of 14 years to life in prison. So, and the only country that actually acknowledges same-sex marriage is South Africa. So this was not a place that was going to be easy for him to live. So this is really a little bit of his story, and I will say that our asylum seekers that we see in our program are really quite interesting, and interesting is not the right word, really quite resilient in their journeys and the stories that they have, and then their abilities to really move on and make a new life for themselves here in this country. So he was no exception, and his story was kind of interesting. He started out so usually there's like a pre-migration story and the post-migration story. His pre-migration story was that he lived in Nigeria. He realized that he was bisexual somewhere in his teenage years. I think now he would probably identify as being gay, but he, at that time, thought he was attracted to both men and women. He basically, at some point, decided he was going to get married in about 2008. Got married, tried to have a relationship with a woman, had 2 children, and then around 2015 or 2013 decided that he really needed to, live a different kind of life and needed to live as who he was, and split up from his wife and then started living with, having a relationship, with a man. At that point, about a year later, he was found out and he was caught by a vigilante group, kidnapped, tortured, really severely, dragged through the streets of Lagos, stabbed, and he actually escaped from imprisonment and went on to live in hiding for a couple months. Got out of hiding, was walking down a highway one day and happened to bump into a reverend that he knew as a child. That reverend agreed to help him to get him to Mexico. So he's kind of smuggled him in as a missionary with a group of missionaries that he was sending to Mexico. In Mexico, he then crossed the border. He went through the Rio Grande. He crossed the border kind of on a dangerous journey to the US. He then was picked up by the CBP, which is the Border Patrol in the US, was sent to a detention center in Elizabeth, New Jersey, which is where we found him. And then he became a patient of our clinic and ended up, he had a lawyer and ended up eventually getting asylum about a year ago. So it took him about 2.5 years from the time we saw him to get asylum. So here's an example of the type of patients that we see. We are in the midst of the largest forced exodus of human beings since World War II. Every minute, 26 people leave everything behind because of persecution or war or terror or some sort. Also, climate change is becoming a really big source of conflict in the world. So I think that's something to really think about. And over half the world's refugees are children. So this is just a sort of snapshot of the types of the different categories of people that we speak about when we talk about forced migration. There are about 71 million people that are forcibly displaced in the world right now. They're divided up into these 3 groups. So about 41 million of them are internally displaced. So within their own countries of origin, they may be living in a refugee camp. They may have to have fled from their home country, their home city, because it's not safe, but they're within their country. Refugees, about 26 million worldwide, are people that have a fear of staying in their country of origin. They cannot stay, they've been persecuted, they're not able to live there, and they flee and they go to a different country. The difference between asylum seekers and refugees are really place. So refugees get asylum or get a protected status from another country before they arrive. So it could be like a Syrian refugee that the United States of America will admit before they get to our borders. And we will tell them, you can come here. Usually they have like a welcome package. They have a direct route to citizenship eventually. And they may have a school for their children to go to. They may have, a family that mentors them for a few months. Asylum seekers don't have that. They arrive at the doorstep of the country to which they're going, also fleeing persecution and hardship, and they come with nothing. So they are, of these people, probably the most vulnerable group. And they then apply for protected status once they're in the country. So just of interest, these are the 3 countries which have from which the majority of people came, were forcibly displaced in the last 2 years. So South Sudan, Afghanistan, and Syria. And also interestingly, about 85% of the world's displaced population are living in developing countries. So yes, Western countries do give quite a bit of money for people that are forcibly displaced, but actually the people themselves, the people that are displaced, are living in countries which have very low GDPs. So just to put everything in perspective that we'll talk about today, the human rights, the Universal Declaration of Human Rights was really the cornerstone of where many of the current day thought on human rights comes from. This document came out of, it was just had its 70th birthday last year, and it really came out of the ashes of World War II, when people all over the globe said, we're not going to, we're going to change things from now on in how we recognize the rights of people. So the Declaration of Human Rights basically says all of these things, that people are entitled to well-being of the individual, promotion of health and protection of health, the right to education, the right to work in good favorable conditions, advance forced marriage, and then lastly it said that everybody has the right to seek and enjoy asylum in a country and relief from persecution. So I just want to give a quick definition of torture. So it is the infliction of severe pain, whether physical or psychological. It's intentionally inflicted for such purposes as obtaining an information or a confession, punishing an act committed or suspected of being committed, or intimidating or coercing, or for any reason or based on discrimination of any kind. But most importantly, it has to be inflicted by or at the instigation of a public official, or the acquiescence of a public official. So what that means is that if my next door neighbor does not like my political opinion and decides to attack me, but I can go to the police and the police will protect me, that is not torture. But if the government inflicts that pain on me, or if, let's say, a gang that rules with impunity in, let's say, Guatemala, does the same thing, and the government and the police have no way to control that person or that gang, then that could be considered an act of torture. So these are the 5 reasons that people come, the 5 grounds upon which people can apply for asylum or protected status in the US. It's race, nationality, religion, political opinion, or particular social group, which I'll explain in 1 second. But basically a refugee or an asylum seeker is coming to a country that they are seeking asylum in because they are unwilling or unable to return to their country of origin, because they have faced persecution or they have a well-founded fear of future persecution. So it doesn't mean if you have seen every member of your family, killed because of their ethnicity, and you know that you're probably going to be killed. You do not have to have faced harm yet to be able to be eligible for asylum. You just can have a well-founded fear that that might happen to you. Sorry, and a particular social group is actually the largest growing category of asylum seekers. And what this really is it's membership in a group where there's some kind of immutable characteristic. It could be sex, it could be color, it could be kinship, it could be your sexual orientation. And it's something that is not expected to change and that you should not have to change. So I'm going to go through this slide really, really quickly, but these are just the different ways that you can get into, that you can become a refugee or seek asylum in a country. The top arrow is the way we talked about just a little bit ago, where if you are a refugee, you basically have some kind of protected status before you enter the country that you're going to. Affirmative asylum means that you come to a country with a valid visa, and then you present yourself to an immigration authority and you say, I fear going back to my country. It's a much more, I would say, a less adversarial process than if you come in on a defensive path, which I'll talk about in a second. And generally, you don't have to go before an immigration court. You just go before an immigration officer for a hearing. The two bottom arrows really are the defensive ways to get in, and basically either you overstay your visa and then you may be picked up by ICE, or you have some sort of way that you are found out, or you will present yourself at the border without documentation. And more now and now people are being put into detention or being held, let's say in Mexico in this point in time. So that is a much more adversarial process. It means that you have to go before an immigration court. Oftentimes, you're immediately put into deportation proceedings. So it's a very different process than going through the affirmative. For all of us, just to know, this country's had a big switch in policy in the last few years. So since 2016, the rates of admission for refugees has dropped drastically. We used to take about 85,000 refugees a year. These are people that, again, are coming to the country, have some kind of protected status before they get here. Last year, we took only about 22,000, and this year the cap is set for 18,000. So these numbers are really shrinking. And on the right, you can see these are it doesn't project that well, but these are the states to which refugees often will settle initially. So very often border states like New York, California, Arizona, Texas are the big ones. So while the numbers of refugees being admitted are shrinking, asylum seekers are growing, and people are still still presenting to this country because they're still fleeing from things that are conditions that are not livable. So in 2017, the numbers are a bit off because the Department of Homeland Security releases numbers about 2 years behind, but we know that there are about 26,000 individuals granted asylum in 2017. This was about 10% of all the cases that requested asylum. About 22% of all asylum cases are completed in New York City. So I always tell people that are interested in this work, if you are interested, this is a great place to be doing this work. The most common countries of origin that we see asylum seekers from are China, the Northern Triangle, which is El Salvador, Guatemala, and Honduras, and Mexico. And the prevalence of torture among refugees is quite high. It's about 43% of all refugees and asylum seekers that have faced some type of human rights abuse or torture in their lifetime. And the wait times for asylum have really, really skyrocketed. So at this point, about 2018, the wait time to have your case have an outcome is about 1,000 days once your case began to be adjudicated in immigration court. Currently, there's about a 1 million case backlog in the immigration system. So people come, they expect to, have some kind of outcome, and often they're waiting for years and years and years to get one. I think the uncertainty and the waiting often adds to mental anxiety, sometimes to physical health decline and things like that. So some of the problem. I'm going to talk a bit about the southern border because that is where I think we've been hearing most of the, in the news, most of the issues coming from. Basically, this is where many people come at this point through our southern border. So families are coming from El Salvador, Guatemala, Honduras, as I just mentioned. They're full families. Sometimes they're unaccompanied minors. Sometimes they're children, pregnant women, and they are coming over the southern border. This is the area of the Northern Triangle, which I was talking about, Guatemala, El Salvador, and Honduras. So why are people fleeing from the Northern Triangle? There's many, many reasons, but I think the big ones are drug cartels, and a lot of times women that are fleeing from situations of intimate partner violence. There's a culture in these countries that sometimes really turns a blind eye to violence against women and gender-based violence. And so these countries are quite dangerous for women to live in. And many times women and girls will come from these countries seeking a safer life. The region is also sandwiched between one of the world's largest drug producers, which is South America, and one of the world's largest drug consumers, which is the US. And because of that, they're the MS-13 and MS-18, which are the two big gangs that really do rule those countries with impunity and control a lot of the drug money. They are very dangerous places to live. There are children that are recruited for these gangs at ages as young as like 12 and 13. And I think once you're in them, that's considered like your life is basically changed forever. So a lot of families are trying to flee with their children way before that happens. Migrants usually come from the southern border through this very dangerous route up through Mexico. Oftentimes when they make it to the US, they're traversing the Rio Grande, which is not a safe journey. There's often extortion on the way, kidnapping, sometimes rape. And then once they get here, they are then faced with Border Patrol on the US side. So we've had several changes to immigration policy by this administration since 2017. These are some of them. So everything sort of revolves around the zero tolerance policy that many of you have heard about, which is that all entrants now to this country will be considered to have committed a federal misdemeanor and are immediately placed into custody. So if you come over the US southern border, not any other border, you will immediately, and you don't have proper documentation, you will immediately be placed into custody. Children cannot go to jail. So in April to June of 2018, the government started separating minors from their families, which caused quite a stir. They then reversed that policy in June of 2018, but what they said was we will put you all together as families, but we will detain you indefinitely. So now there are many, many, many families that are being detained, thousands of families in detention centers all over, but mostly at the Texas border. And they've been there for months, and maybe sometimes years. Oftentimes they are quickly deported though, if they're unable to really show have a good case in front of a judge. And then lastly, this is a new policy that was implemented about a year ago, which is called the Migrant Protection Policy, which is really also known as Remain in Mexico. And what this says is that you cannot come to the United States to adjudicate your case. You have to stay on the Mexican side of the border. And you can come back and forth, let's say for half a day to see your attorney, et cetera, and to actually see the immigration judge, which you may have to do to help move your case along, but you must wait on Mexico's side. This has caused tremendous problems. It's really just been described as like a refugee situation, but without any oversight from the UN. So, it's probably a better situation to be in a refugee camp somewhere, in Syria, maybe. I don't know, but I think I've heard that because there's no oversight, it's really, really horrible. And there's both, illnesses and diarrheal illnesses in children. There continues to be extortion and gender-based violence against women, particularly in these like tent camps that have been set up on the other side of the border. So not a very good situation at all. And one that obviously, affects health and well-being. So I'm going to talk for like a very quick time about our program, just so that I can contextualize some of the things that I will be talking about. So we provide, the Mount Sinai Human Rights Program is a dual service program. We have a mission for both service and education. We provide pro bono, trauma-informed medical, psychological, and gynecological evaluations, forensic evaluations for asylum seekers. And what this means is we document scars and we document psychological trauma that patients have undergone. And if we feel like we're comfortable with it, we will write a medical legal affidavit to corroborate information that the client will have provided to their attorney for their immigration case. We see clients in the community as well as in immigration detention centers. Asylum seekers that we see have suffered human rights violations, including psychological, physical persecutions, human trafficking, often in their countries of origin, female genital mutilation or cutting, and oftentimes severe domestic violence. And we also provide evaluations for unaccompanied or accompanied minors. And finally, we link our clients to continuity care, medical and psychological services if they desire, and social services as well. We have 2 social workers that work with us. On the education front, it's a faculty student run program, so medical students actually do a lot of the heavy lifting for us at Mount Sinai. They're generally preclinical, so first and second years, and they run everything from helping us with the clinic management, they shadow cases. Residents also are involved in that regard, and so I know some of you have trained with us and may have shadowed some cases. We have a whole host of psychiatry residents at Sinai who actually have a license, and so have licenses, so see cases for us as well. We have EM residents that do so as well. So it's a really great way to do global health locally. And it's also a lot of our students have become involved with us in terms of research and advocacy work. Our program sees about 200 clients a year. We have trained about 195 people last year in education, clinical research, and other kinds of advocacy skills. And we have a training every fall. And then we're trying to get an online training as well, so that if people cannot make the fall training, there's something online. That's in the works. About 44% of our patients have been linked to social services and continuity care, and then our grant rates for our asylum grant rates about 98%. These are patients that are very, very well vetted, I would say, so the lawyers usually do a good job of making sure that the patients that we see have really legitimate claims, although I will say that most asylum seekers do have legitimate claims, despite what we might have been told by other folks, but our rates are quite high. So we see about 1 in 3 of our clients come from either Honduras or El Salvador. We tend to see a lot of people from the Northern Triangle. There's some reasons for that, which I won't go into, but some programs just have like a predominance of certain types of clients, and that's who we see a lot of. And then secondly, we see a lot of patients from Sub-Saharan Africa. About 3/4 of our patients are women, 1/4 men, and we have a very young population generally. Most of our clients are between the ages of 25 and 36. Okay, so I want to talk a little bit about impact on mental and physical health and asylum seeking and forced migration. So, I mean, anytime that somebody flees, it's usually because they are, fleeing something very dangerous. So oftentimes, they are persecuted in their country of origin before they come to this country. They are usually, sometimes they will have to flee in the middle of the night. Asylum seekers can be anybody. They can be students that went to one rally at, one time. They can be doctors, they can be lawyers, they can be artists. And so a lot of times these people will have fled imprisonment in their country under conditions that are really quite inhumane. And so they may have been forced to sleep in really crowded conditions. They may have contracted TB. Oftentimes, unfortunately, there's sexual abuse or sexual assault within as part of torture. And so sometimes people come with STIs and nutritional deficits as well. And they also have a chronic lack of healthcare. So by the time they get to the US, we're seeing people that have exacerbated health issues, both short and long-term psychological sequelae as well. In terms of what we see in our program, this is very common, I think, across the board for most programs, but these are the characteristics of the types of abuses that we see. By far, the most common abuse that we see is psychological. And I think that's common for almost every program that I know of. Partly, what happens is that torture over time and abuse over time, scars heal and physical trauma heals, but people always carry the psychological sequela of trauma with them. So most of the patients that we have, most of the requests that we have, I would say over 50% are for psychological evaluations. About probably like 35% are for physical evaluations, and the rest are for GYN. And many of our clients have faced abuse as children. And many of the patients that we see, the perpetrators of the violence, are people that are intimate partners of theirs, or oftentimes gender-based, oftentimes gangs as well. The clients that we see also have, as I said, psychological issues. So we often screen, almost all of our evaluators will do a screening for psychological trauma, even if they're doing a physical evaluation. About 75% of our clients have some signs of depression, about 70% have signs of PTSD, and 62 or so have signs of anxiety. And about 1/3 of our clients have had suicidal thoughts at some time. So these signs and symptoms, which we often see, also make it very difficult often for our patients to be able to tell a very linear narrative to an immigration judge. Oftentimes they don't want to talk about the traumatic experiences that they've gone through because it will trigger PTSD or will trigger memories of what happened. So they really make a big effort to avoid talking about it. And then they're put in a situation in immigration courts where they have to talk about what happened. And so oftentimes we are being called in to substantiate reasons for why they may have had trouble revealing in a linear way what happened to them or the most difficult, intimate parts of their lives. Because a lot of times what happens in immigration courts is this: if there's any inconsistency in a client's narrative, the case can be thrown out. So it's really important that people are able to give a good narrative, and if they can't, we can help explain why that might be. I do not have a clock or a stopwatch. How are we doing for time?
You're fine.
Okay.
It's 20 past.
Okay, great. Thank you. So specific types of torture. So we see predominantly in terms of physical torture, we see blood trauma. I think there's a couple reasons for that. One, it just, it's kind of like the easiest type of trauma to inflict on someone. However, I think the other issue to keep in mind is that when perpetrators of trauma, of this kind of torture or trauma, are thinking about what they're doing, they're really sending a signal to communities and to the individual, and they are giving a warning. And so you don't necessarily want someone to come back to their community, their city, or their village with, a huge scar across their back or their face. You want to be able to sort of subtly do this, send a warning, and then potentially, if you wanted to, if you were a perpetrator, do it again. So blood trauma is a common kind of trauma, which means that we often don't see huge scars on people's bodies that present with 10 years or 5 years after the injuries. But we can go back and sort of get a good history and sort of piece together what might have happened. We do see a good deal of injuries from sexual violence and also blunt head trauma as well. Sorry, so going back to our patient Isaac, when we did the physical exam on him, he described this it's called a cutlass, this very large type of knife that this gentleman is wielding in the picture. He was attacked by a weapon like that. And because of that, he had multiple, I don't know if it's not projecting quite well, but he had multiple linear scars all over his arms. We're showing one of them, but multiple linear scars that were both irregular. Some of them had regular borders that he described as being as a result of that. And we thought that that was a consistent type of injury. He also had tenderness and chronic swelling on his scalp from blunt trauma. Even though the injuries had been years before, he still had these headaches as well, and probably because he had repetitive, concussions from being hit multiple times. And he described passing out over several of the beatings that he underwent as well. The other thing that we noted was that he had described being dragged across a road, a cement road in the middle of the city. And he did have these very rough, like textured, irregular scars. I don't have a picture, but I don't know if you can see it. There's rough, like a very rough, irregular scar on his elbow. And so these are things that we would describe in a medical affidavit, along with the mechanism of injury. In terms of his psychological evaluation, he did screen positive for PTSD and depression. He had difficulty sleeping. He was frequently reminded of the trauma. He did not want to be in large groups. He particularly avoided being in groups of Africans because he didn't want to have to talk about anything that had to do with Nigeria. He also described loss of appetite, insomnia, feelings of worthlessness, difficulty recalling specifics of events. So I want to talk a short bit about detention because I think it's important, and also more and more of our clients are ending up in detention centers because of the changes in policies. And it's really a place where criminalization and re-traumatization occurs. So this is a picture of the Elizabeth Detention Center in Elizabeth, New Jersey. It is run by ICE, which is the Immigration and Custom Enforcement. It is quite a depressing place. I go out there quite a bit to see clients, and it was an old warehouse. It has just the windows at the very, very top. I mean, it's a windowless, dark, dark place, kept extremely, extremely cold intentionally. There's not a lot of time for exercise for the people that live there. Clients are really treated like criminals. They are given orange jumpsuits. The population is all immigrants, are all asylum seekers. So in a way, that's a plus. Sometimes asylum seekers are housed with a criminal population in jails, but it's basically a jail. So in these detention centers, there is a lack of access to nutrition, to laundry facilities, toilet facilities. There's often interrupted sleep with guards coming in the middle of the night and sometimes, disrupting people's sleep to just because, or because they do counts frequently throughout the day. It's severely cold. I'm going to keep saying that, but I've never been to a colder place. And there's not a lot of exercise, as I said. There's really not great access to health care in detention centers. I don't know if any of you heard 2 summers ago, there was a couple of deaths of children in South Texas Detention Center who had come across the border and they were severely dehydrated and they just didn't get care. They didn't get sent to a hospital in San Antonio, which was 70 miles away, for like 2 days or 3 days, and ended up dying. So sometimes you really have to push for patients in these settings to get health care. People often do come to, as I said, to this country already with a sort of poor baseline existing health conditions, and so being in detention does not help that at all. These are unregulated sites, so many of these detention centers are subcontracted to private companies, which don't have any oversight from the federal government, really. So things will go on there, such as physical abuse and sometimes, unfortunately, sexual abuse as well, that are often unreported. And also these places, detention centers, are big money makers. So that's another issue, which I think it's sort of a separate issue, but there's not a lot of incentive to close them from the private sector because they are making tons of money on keeping these places open each day. And just to note, the prevalence of any kind of medical condition that somebody may have who's an asylum seeker in detention really can cause great worry. And this may ultimately then affect their health and affect their psychological health, and then affect their ability to tell their story, like we talked about before, in a linear fashion. And that may then ultimately affect the way that they are able to obtain protected status. So detention at the border is another entity in and of itself. Oftentimes when people come through the southern border, they will be stopped by CBP, by Customs and Border Patrol. And before they even get to a detention center, which seems like a dream compared to what I'm about to describe, they might be held in holding cells by CBP for what's supposed to be no more than 12 hours, but is often up to 3 to 4 days, sometimes longer. So these are holding cells. They don't have any beds. You are just like sleeping on the concrete floor. Really cold temperatures, intentionally being forced to sit or sleep on concrete for multiple days in crowded rooms. There's really very little access to food or water, sometimes none. No medical care, and often always, I would say always, no communication with legal counsel. So this is a picture on the left of La Herrera, which is the icebox. These are people in Mylar blankets sleeping in these really freezing cold rooms. On the right, these are what's called the dog kennels, where people will be lined up sleeping, in a caged area for several days. So you can imagine, after you've made your journey across the Rio Grande, or you've made your journey from Guatemala, maybe you've met with somebody who's extorting money from you, maybe you've been sexually assaulted on the way, and then you get to the US, and then these are the conditions you're staying in, and oftentimes, your health has deteriorated on the way. If you have asthma, being in a 50-degree box is not a great place to be. If you're a child and you're dehydrated, all the same. So, not good conditions. This is an interesting study that actually came out a while ago by PHR, Physicians for Human Rights in Bellevue. Just briefly, it talked about, it investigated 5,000 asylum seekers who were in detention, and administered what's called the Hopkins and the Harvard traumas, the Hopkins scale for anxiety and depression, and the Harvard trauma scale for PTSD, which are both validated tools in refugee populations. So what we found was 3 things. That at baseline, everybody had a high incidence of depression, PTSD, and anxiety anyway. There were a lot of similarities in this population to incarcerated populations, criminal incarcerated populations, but being an asylum seeker and being in detention had a whole other factor of uncertainty, which led to hopelessness in a lot of patients. Once in detention, about 70% of the population had worsening mental health. And this correlated also with the length of time that one spent in detention, as well as the experiences that they might have had in solitary confinement, which I didn't even touch on, but you can be sent to solitary confinement. Sometimes because you're depressed and you don't want to get out of bed, sometimes because you might have had a bad day or maybe an argument with another detainee, but people often do spend time in solitary confinement, which worsens mental health. After release, there's also, there was some improvement. People actually, of course, felt much better being out than in, but they reported that their mental health never really went back to baseline, that being in detention affected them long term. And they also interestingly said that they would do it again, that, even though they had this horrible experience, that they wouldn't have deterred them. So there's really not a lot of evidence that detention deters people from seeking asylum, because they often really, what they would have to go back to is far worse than what they have to deal with in detention. This is an interesting study that one of our medical students actually headed 2 summers ago at a Texas detention center. She and our team looked at trying to determine the rates of behavioral and emotional problems and PTSD in children ages 4 to 17 that were held at this detention center. It was an interesting time. It was a time during which the Trump administration had just ended separation for families. And so what happened was this detention center had women and it was for women and children. So women and children that were families that were maintained, and then there were children that had been separated that were now reunited with their mothers. So two groups of people that we got to really look at. We interviewed 420 mothers, and we gave them what's called the Strengths and Difficulties Questionnaire, which asked them about behavioral issues in their children, about behavioral issues in their eldest child, ages 4 to 17. And then we took a subset of the population who were ages 9 to 17 that could read, children that could read and write, and we administered a PTSD scale to them separately. So what we found was, first of all, 95% of our respondents were from the Northern Triangle, because that's just where people were coming from who were held in this detention center. We found a very high rate of emotional problems in general and difficulties in these children. So regressive behavior, aggression, things like bedwetting in teenagers, hyperactivity, getting into fights with other children. And particularly we saw this in younger children, so ages like 4 to 8 years old, and in children who had been forcibly separated previously. So those two groups of people, of children, really had difficulties. We found also, this was kind of a shocking number, but we found that the prevalence of PTSD, what we thought was PTSD-like symptoms, was about 17% in the sample that we interviewed. Whereas the lifetime prevalence in adolescents in the US is only 4.7%. So huge difference in PTSD in this population. We could not say that this was causal, unfortunately. Not unfortunately, but we couldn't really say that, you know, arriving in the US and the time in immigration detention led to this development. But what we could say was that these are mental health issues that exist in detention for these families, for these children. There's almost zero mental health care in detention centers. So there needs to be some kind of culturally responsive, trauma-informed care that people get while they're waiting for their cases to be heard. Okay, so what is the role of all of us in documenting these abuses, if you so desire to be involved in this work? So this is a nice little Venn diagram that I like to talk about. So we really, when we do this work, we bring our medical knowledge, which everybody has in this room and the other rooms for which we are conducting. We read up on human rights abuses. We, we'll look at the country conditions in the country that we are seeing a client from which the client hails. We will look maybe a little bit about the political climate in those places. And then the last thing is that we will bring forensic knowledge to the table. So that forensic knowledge can be gotten in several ways. We do trainings in our program once a year. We are, as I said, trying to have an online training at some point. And there are other trainings throughout the city about 2 times a year, both in the spring and in the fall. Cornell and Columbia have trainings as well. And other places also, like New Jersey, I know has a new program. So there's always a place to get trained if someone so desires. And then there's the work that we do is really at this confluence of all 3 of these things. And we follow something called the Istanbul Protocol when we do this kind of forensic asylum work. What that is it is the manual on effective investigation and documentation of torture. It was just a document that was really put together in the 1990s. It came out of an autopsy of a Turkish man who had been tortured. And it sets out very specific guidelines on how to investigate both medically and legally acts of torture. It is not a legally binding document by any means, but nations are required if there is some kind of government-sponsored torture that is known about, they are required to investigate that. So this is really kind of like our Bible, our guide for how to do this medical work. So what we are really doing is we are documenting, and we're documenting according to the taxonomy of the Istanbul Protocol, which is about consistency of a scar. We are basically saying this scar is consistent with, or highly consistent with, or maybe not consistent with the mechanism of injury that a client describes to us. And we also are describing common both physical and psychological signs of torture, like that we talked about. Any kind of behavior that a client may have that may make them non-credible, because again, that's an important thing for immigration judges to understand. why somebody may not be credible because they have severe PTSD or they have severe anxiety about speaking about an issue. Maybe oftentimes the legal system, authority figures in the legal system will trigger for people, authority figures that might have abused them in their countries of origin. So this is all very important. And also, lastly, it's to bear witness. And so I think it's important to say that even though we are trying to do our best to document objective signs, sometimes even if there isn't anything to document, just hearing the patient's story, just bearing witness to the trauma that they've undergone can be really therapeutic. And we've been told that on several occasions. So I think that's something to keep in mind as well. And then if we find that there's something that we can support, if we find that there are medical or psychological findings that we can write about, we will write about those in a medical legal affidavit, which we will then present to the court, or the client will present to the court. And we are very careful to be very objective in this kind of writing. We are advocating for human rights in general, not for that one client, but at the same time, we have to, we hope that we can do them some good, but we also have to be very objective in the way that we write our findings down. And it is not our place in any of these affidavits to promote our own political opinions or feelings at all. So this is a very objective document. We know that why do people ask for forensic evaluations? Well, a study from PHR from a few years ago showed that with an evaluation, with a medical forensic evaluation, there's about an 89% chance of obtaining asylum in this country versus about 37% without an evaluation. So I think more and more now attorneys are asking for these evaluations because it's becoming harder and harder to get asylum. And the more objective data that you have to support your client, the more likely that they may get asylum. The other thing is that we know that through evidence, we can enact change and we can advocate for human rights in general. So every time that we write a medical legal affidavit, we actually are educating the judiciary system. We are educating them about, what psychological signs are that in trauma. We're educating them about physical signs, and we're advocating for human rights collectively. So I want to talk really quickly about the prevalence and screening, coming back to the question of, are you seeing individuals with histories of persecution in your practice? So this is a study by David Eisenman and Alan Keller from a while back, where they looked at 121 adults that were foreign born in a primary care clinic, ambulatory care clinic. They found that 6.6% of them had histories of torture, and that none of them had previously been asked about that by their doctors. Sandra Crosby and her team, also in an ambulatory care clinic setting, found that 11% of 142 patients reported histories of torture, consistent with the UN definition of torture, and only a third of those patients had ever been asked or had ever disclosed that information. And then this is at our sister hospital at Elmhurst. This was a study in the ED where they looked at all comers, and they said that 470 patients were interviewed. They found that about 6% of those patients had survived some type of torture. That's consistent with the UN definition again. 78% of those said that they were never asked by a doctor about that torture. So I think the take-home point here is that it is prevalent. We are seeing it in ambulatory care settings. We are seeing it in primary care clinics. We are seeing it in the ED. And if you don't ask about it, you may not know. There are definitely detailed screening tools that are pages long to basically lay out whether someone has officially met the definition of UN definition of torture and to screen, but you do not need a very detailed screening tool to be able to get to the bottom of maybe whether somebody has been tortured or has faced human rights abuses. You could ask simple questions like, what made you leave your home country? In your home country, did you ever have problems with the police or with the government? Or were you ever persecuted for any reason based on your political beliefs or religious beliefs? And if you do see scars on somebody's body during a regular physical exam, you can and probably should ask about them. And how did you get that scar? I mean, I think it's something that we often feel is an intrusive question, but from the data that we have from studies, patients, those other studies I just talked about, patients were actually quite happy to finally be asked about the trauma that they underwent. So why do we screen? So like I said, we definitely want to screen so that we can get a holistic and a diagnostic plan for patients. Oftentimes, if somebody has back pain, we might want to know whether it's because they were in a forced position for 2 weeks and have ligamentous injuries versus, they just picked up a heavy object and it's going to go away in 2 days. If we yeah, I mean, if somebody has faced sexual abuse or trauma in their past, we definitely want to know that as part of their history. And then we also want to be able to offer them an opportunity for asylum if that's something that they desire. So if you do find somebody in your practice that seems to screen positive for being a survivor of torture or human rights abuses, you'd want to document that in the medical chart, of course, incorporate that into whatever plan you have, into your treatment plan. Refer patients to the proper trauma-informed care, which I'm happy to also help with that in any way. We have plenty of referral systems within our program, but also, just generalized care, continuity care is often the beginning of what people need. And then secondly, you want to refer people, offer to refer them for help in potentially getting asylum. So not everybody that has undergone torture would meet the ground, that has a scar in their body, I should say, will meet the grounds for asylum. And sometimes people flee countries for different reasons, but many people actually are eligible for asylum or some type of protected status because of their torture history. So you can tell them, would you like to speak confidentially with somebody? And you should also very much stress that whatever they tell you will not threaten their immigration status. Many people do not want to come out in this day and age and, disclose that they are undocumented. So that's something really important. And this is how we actually found our patient, Isaac. He was in the EHOP clinic, which is the student-run clinic at Mount Sinai. We'd had a human rights lecture week on human rights the day prior, and the student went to the clinic and basically saw Isaac the next day, asked the right questions. He was there for like an earache, and identified him as somebody who potentially could seek asylum, and then sent him to us, and there we are. So now that is how it all unfolded. So what are the education benefits? I mean, I think I could go on about this for a long time, but I will just say basically in brief, we hope and we like to think that working with this population, working with asylum seekers and refugees who are an underserved and vulnerable population will bring a certain depth and of practice to both residents and students. It will prepare you it is a way to engage in global health at a local level. You can become agents of change in your community. You can develop leadership skills. Definitely our students develop leadership skills and get to collaborate with people from multidisciplinary backgrounds. So we work with social workers and lawyers and psychologists, and they get to work as part of a team. It definitely develops cultural competency. And anytime that anyone goes to an immigration detention center, it is a very sad but very fascinating experience. It is like really doing prison health, and it really, like, I can say without doubt, lends a new level of understanding about healthcare in this population. And also sometimes you bump up against dual loyalties when you work at a detention center, because you are, in that case, often I found myself trying to advocate for a patient's health needs within the system. If after I see a patient, I will say, like they need to see a doctor, they're severely anemic, or some symptoms that I will uncover, and then it's sometimes very difficult to get that patient seen properly in the clinic. And so there's this sort of dual loyalty of working within the system and then also working to advocate for the patient's health needs. Yeah, and these are some of the ACGME milestones that we hope we hit on when we do this work, in terms of patient care, medical knowledge, professionalism, interpersonal skills. So if you would like to get involved in this work, there are many ways to do so. We are not the only program in the city, but we would love to have any of you who are interested become involved with us. You can go to our website and you can click the Get Involved tab and you can sign up and we will email you back. You can email me directly. And we have trainings twice a year. We have trainings once a year in our program in the fall, and then other programs have trainings as well in the spring coming up, like late February, early March. So if there are any questions at all, I'm happy to take them.
Rosa, thank you very much.
Sure.
For the wonderful talk, and also for all the great work. And I realize this is the trauma survivorship being so common. I should have set up your lecture for our audience, just in terms of saying, if anyone has that history, my apologies that I didn't call that out. Just wanted to call that out. Also, just in hearing you, you touched on it at the end. I just wanted to get your perspective on The challenge I find that I've had with patients with this kind of history, I haven't seen a lot, but I know I've seen some, is keeping my mind focused both on their immediate needs, but also things around prevention and health maintenance and things of that sort. And I just find I often get, I don't want to say distracted, but I'll forget to ask, would you like to receive a flu vaccine?
Right, right.
And so I just wondered if you have experience with that, maybe some ways about how to make sure we're doing the basic parts of good health care, even as we try to.
Yeah, no, I mean, I think you're right. So I personally don't do the continuity care for these patients, but that's an excellent point. And one of the things that we find is that even in young after we see them for a forensic evaluation, which is a one-time meeting generally. Sometimes people will get both a psychological and a physical, but it's usually a one-time meeting. These patients are often young, they're often healthy, and we forget that, but they often haven't seen a doctor or any kind of healthcare professional at all, or for years and years. So we often forget that, yes, they need this type of care. So we always offer continuity care. We try to get women, hooked up with GYNs. But I do think that in addition to the chronic issues, yes, they are, we have to treat them as in a holistic way. And ultimately that's, they're here to get on with their lives, and they're not here to be a statistic or to be a survivor. I mean, I think they're happy to be called that, but in general, they want to go on with their lives. So yes, general healthcare is incredibly important, and we try to stress that to the people that thing. And we actually train a bunch of our primary care physicians at Sinai who will then take on these patients. So they have both sides of their brain working in terms of continuity care and forensics. Yeah, sorry.
Well, I can tell you a story, and then I have two questions. First is I'm older. So as a consequence of that, my experience was in the Second World War. And my mother shaped my sister in the ball and dressed as boys, so we would have the race against the soldiers who would walk into the homes and take whatever they wanted and do whatever they wanted. And they raped babies to 98-year-old women. So it was a very terrifying experience. I had to explain to a kid why they're being shaved bald and dressed as a boy, and why you have to do it. So that's one experience that's hard to forget. That's why I have long hair. But anyway, that's my own experience. The other is, obviously, there's a large proportion of people who do not have some of these features that you really need to expose. And the question is, what is their resilience? And can we learn from them how to apply that to the people who are affected? And could that actually be another research tool that would help us because they come from their own cultures, so are there other factors of resilience that help them to navigate this life journey?
Yeah. So first of all, I'm so sorry to hear about that experience, and that, those abuses should never happen, and we hope that they will not happen again. That said, of course, that is the work we're doing, but yes. So in terms of resilience, that's an excellent point. I think I didn't talk about that in this talk because that's a whole other lecture, but the patients that we see are some of the most resilient people I've ever met. Oftentimes, what our hope is that we are engaging in what's called trauma-informed care. So we're actually keying into the patients and to see what they think is, strength-based care, where we are keying into their strengths. So we're trying to see what can we do to take that strength and build on it. So whether that's from a psychological point of view or physical, etc. And also in terms of resilience, a lot of our patients don't have a lot of physical scars. You're absolutely right. And many of them also, because they are the ones that survived and got here, they may not have a lot of psychological trauma. They may just have survived. And we often do just document in our affidavits that, they are resilient. These are the 10 resilient factors that they have. And this, even though you're not seeing these people, they're seeing their trauma, they've undergone it. So a really good point. Sorry.
Thank you, Dr. Singer, for the great talk. Marcelo, all of the questions here. So I am from El Salvador originally. So as someone who comes from one of those countries and is an immigrant in a different way that the people that you see at your practice, first thing I want to do is just to thank you for the great work that you do for these people. Thank you and the group for that amazing work. And I had one question regarding the follow-up, the continuity of care for these patients. You mentioned that some of the patients that you see have chronic conditions, so if they don't have health care or health insurance, where do you refer them?
So one of the nice things, one of the good things that hasn't been taken away yet, is that anybody that's filed an asylum claim is eligible for, in New York, different in New Jersey, but in New York, is eligible for Medicaid. So all of our clients that we have, we immediately will cook them into our social services. Once you have your application, I think it's like 60 days, you can apply for Medicaid. The other thing is that we have sliding, at Sinai, we do have sliding scale fees. We have some of our own evaluators who do continuity care for this population, and they're willing to see patients sometimes pro bono. But Medicaid is an option.
Thank you very much.
Sure.
My name is Fernando Ranavali. I'm from Buenos Aires. So one of the things that you mentioned with the witness part is,
Yeah.
that part of the experience, I did have some experience. So the question to you is that, knowing how the shortage of psychiatry care is here, even in New York, kind of help your teams get to be the third witness of all this? I mean, do you have yourself enough support to do this? Because the impact of in the people is immense.
Yeah.
The impact on the doctors and the population in general that is hearing these news is just as concerning.
Yeah, no, great point, and also something that we talk about in our day-long training. What you're talking about is vicarious traumatization, and also, on the other hand, vicarious resilience. So people that do this work long-term and even short-term can often face exactly these things. They will take home, or they will internalize the trauma that other people tell them. Sometimes they also take home and internalize the feeling of this uplifting feeling. You know, you're with somebody who has survived incredible feats of just anything, and you are able to internalize that. But what we do in our program, and I think other programs do this, as I know other programs do this as well, is we have biannual groups that we run with our psychologists. We have actually two really amazing psychologists and psychiatrists, Dr. Kim Baranowski and Dr. Craig Katz, and we run them for our students, for residents, actually for faculty as well. We always open it up to faculty. Faculty tend not to come, but we do invite everybody, and we basically just air these issues, and we talk about how we can support each other in this work. We do, and I think it's very helpful, because it's hard after a while, to hear these stories, and Dr. Shapiro she's one of our wonderful evaluators, and I think you start out and you want to bear witness, you want to hear these things, and then after a while you have to protect yourself as well in order to keep doing the work. Yeah. Sure, thank you.